Greetings from Manipal Hospital Baner, Pune. I am Dr. Karan Chanchlani. I am a radiation oncologist. Today we will be talking about role of radiation in head and neck cancers, especially the oral cavity tumors. Oral cavity tumors are treated differently from the rest of the head and neck cancers. Typically, the first line of treatment here is surgical excision. We need to excise the tumor that is seen along with some margins. We call it wide local excision. Sometimes we also need to remove some glands from the neck nodal dissection we call. And after that, depending upon the histopathological report and its risk factors, we give radiation. Sometimes this radiation needs to be potentiated with chemotherapy also, so we call it chemoradiation. Typically, radiation in the post-operative setting starts after the wound healing has completed. So around 3 to 4 weeks, we start radiation therapy. Maximum, we can wait up to 6 weeks of post-operative to start the radiation, after which the efficacy of radiation decreases. Radiation is typically delivered in multiple techniques like 3D CRT, IMRT, IGRT. So these are the names of various techniques. It is worthwhile to note that the dose in all these techniques remains the same. A typical post-operative dose ranges from 54 gray to 60 gray, which is gray is a unit of radiation that is delivered 5 days in a week every day from Monday to Friday typically, and this goes over up to 6 weeks. So sometimes we need to increase the dose to a very specified area depending upon certain risk factors, which can go up to 64 to 66 gray. Coming to the techniques, 3D CRT, IMRT, IGRT are the routinely used techniques in such scenarios. In 3D CRT, we give a very conventional form of field arrangement for delivering radiation, whereby we have a certain higher amount of side effects or higher incidence of side effects. With conformal delivery techniques like IMRT and IGRT, we reduce doses to the surrounding critical structures, thereby reducing the side effects. Specifically for IGRT, it is called as image-guided radiotherapy. We take a CT scan before treating the patient on the day of radiation, and this goes on each such fraction or setting of the radiation, and we try to match the delineated areas or the targets which are intended for radiation, and also certain critical areas which are to be spared from the dose of radiation. So with IGRT, we can reduce the safety margins of the target or the normal structures that are getting unnecessarily irradiated, and thereby we improve the side effect profile of the patient. Additionally, we are very sure on the precision also. We need to see what we are treating, and that helps in improving the outcomes overall. The side effects normally start after a couple of weeks of radiation has been started, and they typically last for additional 2 to 3 weeks after the radiation has stopped. So common side effects are like mucositis or some ulcerations in the mouth, because of which there would be some painful swallowing, so odynophagia, or some difficulty in swallowing called as dysphagia. Additionally, the salivary function is also compromised because of radiation. This salivary loss of function typically manifests around 2 to 3 months after the radiation has completed, and it increases up to 1 to 1.5 years, after which it plateaus out. So we can, with modern techniques, reduce the dose to these salivary glands and thereby better preserve their function. Additionally, there is some blackening of the skin in the irradiated area, which is a rare phenomenon these days, and there may be some removal of the skin. We call it desquamation. So with better techniques and better precautions, these all side effects can be minimized, and they can be taken up to a tolerable limit. At Manipal Hospital Baner, Pune, we have the most modern technology and a state-of-art facility in the radiation department with a modern linear accelerator that helps in minimizing the side effects during radiation treatment and thereby improving the outcomes. and improving the patient experience.